This is the Tox Course Podcast. It's a sunny day. You're walking into a music festival with some friends. You can hear the bass and you're pumped for a great day. As you approach the gate, you notice that there's several police and a sniffer dog checking for drugs at the main gate. Out of the corner of your eye, you see someone in the queue next to you suddenly reach into their pocket, take out what looks like a couple of small foil packages that they quickly put into their mouth. They grab their friend's water bottle, take a huge swig and swallow the packets down. But in their panic, they failed to notice that they dropped a packet. But the police officer didn't miss it, nor did the sniffer dog, both of whom are striding over quickly in your direction. As you shuffle past, the police officer reaches out, taps the guy on the shoulder, points at the ground and says, "You dropped something, mate, and what did you just take?" Welcome back to the Tox Course Podcast. I'm Andy Buck, and today we're diving into a potentially serious encounter in emergency toxicology, body stuffing. We're talking about desperate drug concealment in the real world, panicked patients, swallowed packets, and split-second decisions that can ultimately result in serious harm. Whether it's a routine traffic stop gone sideways, a prisoner brought in with a bellyache, or a seizing patient who suddenly collapsed in the ED waiting room while waiting with the police. If you work in pre-hospital emergency care and you haven't seen this yet, one day you will. Today's episode is all about recognising, risk assessing, and managing body stuffers. We covered body packers in the previous episode, so if you missed that, go back and check it out. It's an extremely good episode with a ton of practical pearls about treating this high-risk patient group. In this episode, we'll break down body stuffing and we'll cover common presentations, high-risk features to watch out for, as well as treatment options and disposition advice. So let's get into it. This is clinical toxicologist Ingrid Berling, emergency physician Nick Dafters, and myself talking body stuffers.
Body stuffers are a different presentation. So this stuffing applies to the concept that the patient has been in a hurry and they've rapidly had to hide some illicit drugs that they've had on their body or person or in their possession. These are often not well wrapped or they're poorly wrapped, and the risk of leakage is significantly higher. Also, the range of medication or illicit substances that they might have ingested is significantly different to what we typically see in the packer situation. Nick, a patient is presented to your emergency department. They're in police custody and the police think that they saw them swallow something on their presence and they're concerned that this is a body stuffer situation. What would your approach be?
This isn't an unusual situation in emergency. I've seen a number of these patients. I think like any patient, any toxicology patient, there is definitely a risk of toxicity here because they're usually not well wrapped, as you said. So I'm going to do my standard toxicology approach, and I'm going to try and establish a rapport with the patient because they need to be compliant, ideally, with this process. And often this has all happened in a bit of a rush. There's police already involved, so the patient might be a little bit agitated. So often you require a little bit of verbal de-escalation and explanation to the patient about what's going to happen next. But with any tox patient, my first decision note is this patient stable or unstable? In the majority, they're usually stable because it's most commonly relatively small amounts of recreational drugs. But if they are showing signs of evolving toxidrome, you may need to move them to a critical care bed space to start their management. I guess the most common substances in this situation are festival-type drugs. That would be a common scenario. So you're looking at drugs like MDMA, other stimulants. And so these would be the most common signs you might be looking for.
It can be difficult in these early presentations of these patients to elicit their sympathomimetic drive symptoms to whether or not it's related to their presentation, being agitated in police custody, or whether these are early signs that they've got leakage from their body stuffing ingestion. How do you manage that situation?
Yeah, I completely agree. Often we see patients that are really elevated on initial presentation, and often that's just because of the interaction with the police and the stress of the situation. So I think it speaks again to the importance of rapport building, trying to calm down the patient with some verbal de-escalation. And if it's endogenous catecholamines driving the process, usually you can settle the patient down over a period of 5 to 10 to 20 minutes and get a more rational review of what the actual physiology is. I think like any toxicology patient, the trajectory is key. So if you're seeing a patient who's slowly getting worse in the ambulance bay or in the bed space, despite a relatively calm environment, that would be a major warning sign that this might not just be their endogenous catecholamines, and this could be something else on board that's starting to absorb.
So Andy, what imaging modality would you use for this patient? Often the police are requesting an X-ray to confirm ingestion.
So I think it's worth remembering that, like we talked about, in contrast to the body packers who have generally very large numbers of very thoroughly wrapped and often multiple layer wrapped packages of drugs, which show up well on imaging. In the body stuffing situation, these are people who generally in a blind panic, they've been pulled over while they're driving, they have drugs in the car, or they're walking into a festival and they panic and ingest their drugs. Sometimes there won't be any packaging. They will have just taken a handful of pills or stuff some powder into their mouth. Sometimes they'll just be the little clear deal bags and they've swallowed one or two of those. And those aren't generally radio opaque. So the sensitivity and specificity on positive and negative predictive value of imaging in this setting is much less. Also remembering that they generally present soon after ingestion, not delayed like the stuffers. So the packages, if there are any, will generally still be in the stomach. And if you think about looking at stomachs on x-rays, even of the abdomen, they're very hard to see foreign body sometimes, unless they're something like a nasogastric tube that is designed to be radio opaque. So you can't really confirm or exclude ingestion of packaging unless it is potentially metallic. For example, say a bit of aluminium foil that they've swallowed, that may show up on x-ray, but you can't be definitive with it. Another thing, just with regard to what the patient's ingested, sometimes if the police are willing to step out of the cubicle, sometimes I find that helps with rapport building. And if you've taken a bit of time to establish a bit of trust with the patient, that you're not there to be an ally of the police, you're there to look after them, and just quietly ask them, look, what did you take? And was it wrapped up? And what was it in? That can sometimes give you some information that might actually be useful just to help guide your decision-making around imaging, time of observation, etc., things like that. Another thing I am big on in all facets of emergency medicine is the exposure of the patient. So obviously you say, look, I'd like to examine you, but keeping in mind other places that people will hide drugs on their body, because what you don't want to do is say, look, the patient looks fine after having a period of observation in the ED, and you miss a packet of drugs that they've stashed somewhere else on their body. They go back to the police cells and overdose in the cells. So just remembering to check in their mouths, check, under breast folds, under skin folds, in axilla, just so we're just going to check all your skin, make sure everything's fine here. Just look at their backside, look at their legs, try and get them undressed into a hospital gown. You don't need to shake their clothes out, that's for the police to do, but just to make sure you've sort of had a good look all over their body and then there aren't drugs hidden elsewhere on them.
Thanks, Andy. So your patient has settled down in the emergency department. How long are you going to keep them there in police custody, and are you going to give any treatment?
If there's reasonable evidence that the patient has body stuffed and has ingested some substance, I will definitely take advice from my toxicology or poisons information service about the appropriate length of observation time, which will depend a little bit on the presumed number and type of pills ingested. Often these patients will end up in the emergency short stay unit for a period of 4 to 6 hours. And if they're completely symptom-free and we think it was a relatively low-risk ingestion, that's often a reasonable time frame. But I think it's always worth taking advice in that scenario. Another question that often comes up in this circumstance, especially if the patient doesn't initially present with the police, is what you do with small amounts of presumably illicit drugs that are removed from the patient's possession. This obviously is an ethical tension between, the patient's right to have their own personal effects and our duty of care to their own privacy. We have an ethical responsibility to their privacy, but equally, we can't be facilitating drug misuse by providing drugs back into the community. So it's a complicated legal area, and often there are guidelines governing for your state or area what you should do in this situation. Locally, what we would tend to do is small amounts of illicit drugs all things get removed from the patient on arrival, and any presumed illicit drugs get locked away in the controlled drug cupboard for pharmacy to safely dispose of the next day. If there was a very large quantity of illicit drugs removed from a patient, you definitely want to seek some expert advice, ideally from your hospital executive, and potentially some legal advice in that situation as well.
So Andy, have you seen any complications from a body stuffer?
Look, they're thankfully rare. The main ones I've seen have actually been people who've taken a very large amount, I'm talking handfuls of things like ecstasy tablets when they've been pulled over by the police. They clearly look like someone who might be driving around with ecstasy tablets on them. They're late at night, driving between nightclubs, for example, maybe driving a bit erratically. They've been taken down to the police station to be interviewed. And in that time, obviously, their absorption has started and they've started to become quite unwell at the police station, which the police are good at recognizing. They bring them to ED, and by the time they get to us, one case in particular, I remember a young man presented with the fairly severe serotonergic toxidrome on arrival to ED, and he became extremely unwell and ended up intubated not long afterwards and spent the night in ICU. Thankfully, they're generally lower doses that people ingest, and there's a couple of complications that you might see early on, which are generally really obvious. So obviously, if the person is choking on the packet, if they've got stridor or hoarseness, coughing, they say they're choking, they're spitting saliva, it's stuck in their upper airway, that's generally really obvious, and we know how to deal with that. The other place they can get stuck is in the esophagus. So they may have dysphagia, or they'll look like they've got a food bolus stuck. They'll have chest pain, dysphagia, they'll be spitting saliva. And again, we mentioned that endoscopy is sometimes not the best way to remove body packages because of the risk of rupture. However, there's not really any other way to get these out of an esophagus. So these patients might need to be referred for an endoscopy.
Thanks, Andy. So I think the learning points from this discussion for body stuffers is that there's a potential for anything to be ingested. Certainly a 6-hour observation period for asymptomatic individuals is reasonable, but you need to have a high index of suspicion for any slow-release medication that might have been ingested. But it really does depend on the discharge destination for these individuals. Anyone in police custody or from a correctional centre is going back to an observed environment where if they'd start to deteriorate, they can be brought back to hospital. I would have a lower tolerance to discharge someone who doesn't have a safe destination upon discharge, and I would be keeping them for longer in the emergency department. It's also reasonable to give these types of presentations a dose of charcoal because we're talking about a lot smaller level of ingestion for the amount of products taken, and the potential for charcoal to inhibit some of that absorption may change outcome.
Okay, so there you go. That was a fantastic, short, punchy episode on body stuffers. If you found that useful and want to know more about assessing and treating people with illicit drug toxicity, head over to etmonline.com and check out Module 2 of the Tox course. While you're there, check out Modules 1 and 3 because we've got a great deal at the moment. If you buy any 2 modules together, you get a 5% discount. And if you buy Modules 1, 2, and 3 together, you get a 10% discount. And if you're just interested in the free or FOAMed content, head over to toxcourse.com and check out our free Tox blog and podcast. That's it for this episode. Stay safe out there and we'll catch you in the next episode.